Good afternoon, everyone. Thank you for being here this afternoon in another IFS Vibrate webinar. Today, we have amongst us a very special speaker in Dr. Ila Gupta. She is an MBBS MS in obstetrics and gynecology. She is the current director and senior consultant at Ferticity Fertility Clinic, Delhi. She is the co-convener of IFS Patient Resource Committee as well as a reviewer of Fertility Science Research Journal. Dr. Ela is also the former secretary of IFS Haryana chapter. Her areas of interest are mainly infertility, IVF, and endoscopy. She has also been awarded for the best paper on hysteroscopy. She has been a mentor to many doctors in the field of fertility and conducts training courses in basic and advanced assisted reproductive technology for Indian as well as international doctors. She has over 2 decades of experience in her field, and today she will be sharing her expert opinion on a very important topic. So, without taking any more time of her, I would request the doctor to start with the webinar. Over to you, doctor.
Thank you, Suhas, for the kind words, and I welcome all the participants for this webinar. And without wasting time, let's first move on to the topic, which is ovulation induction in PCOS. Polycystic ovary syndrome is a heterogeneous collection of signs and symptoms with mild presentation in some and severe disturbance of reproduction, endocrine, and metabolic function in others. The pathophysiology of PCOS appears to be multifactorial and polygenic. Now, there are many extra ovarian aspects to the pathophysiology, but ovarian dysfunction is the central aspect. And there has been many controversies still attached to the diagnosis and treatment. So, we look at the Rotterdam ESHRE and ASRM consensus group of 2003, the 2 out of 3 criteria required to diagnose a patient of PCOS. Either there should be history of oligomenorrhea or anovulatory cycles. There will be clinically or biochemical features of hyperandrogenism. Or if you do the transvaginal scan, then there should be a picture of the polycystic ovary. So this is a picture of transvaginal scan where you can see 12 or more follicles measuring 2 to 9 millimeter in diameter in ovary, and they are placed peripherally like a necklace, giving an appearance of the necklace. And if you look at the ovarian volume, it should be more than 10 ml in the absence of a dominant follicle of more than 10 millimeter. So what are the learning objectives? Now, before when we start any stimulation for the patient, we should know the physiology. Then there has to be a pre-treatment consideration. Preconception counseling is important. Then lifestyle modification, what is the role of metformin, and what are the options available for ovulation induction for these patients, and the role of laparoscopic ovarian drilling. So one by one, we'll be dealing with these topics. So for ovarian stimulation, when it is performed, the idea is to have mature and good quality oocytes and to have good quality embryos, which provides adequate endocrine milieu to have the good endometrial receptivity. So ultimately, we look for good pregnancy outcome. Now we look at the physiology. We have FSH threshold and recruitment window. So as the Brown postulated that in gonadotropin therapy, the ovary has a threshold requirement for FSH below which follicular development does not occur. So FSH threshold is not fixed for any given follicle. And the follicles, they exhibit different degrees of FSH sensitivity at the time of recruitment, which is highest at the stage of antral follicle and it declines in the late antral stage. So the follicle with meets the highest sensitivity will benefit most from increasing FSH level, but it will gain dominance and ultimately it will ovulate. So not only the FSH is important, the LH hormone is also important for the optimal follicular growth. So there is a LH therapeutic window. Now what is this LH therapeutic window? If you look at the LH threshold, it should be more than 1.2 international unit per liter, which means if the value is more than this, then there is optimal follicular development. So for optimal follicular development, it should be more than the threshold, but it should be less than 5. So less than, if it is more than 5, then that is LH ceiling. So LH ceiling means if the value goes above 5, then it may result into follicular atresia. There will not be any dominant follicle. Oocyte development will be compromised. There will be suppression of granulosa cell proliferation, and there may be premature luteinization of the preovulatory follicle. So what is the role of LH? It enhances the ovarian sensitivity to FSH, promotes dose-associated increase in the secretion of estradiol and androstenedione by FSH-induced follicles, and increasing the successful luteinization of follicle on exposure to SCG. So we all know when the follicle reaches 17 millimeter in size, there's a peak level of E2, with as per the number of the follicles, the estradiol level may be 150 to 200 nanogram per ml, and then it results into the onset of LH surge, resulting into atresia of the remaining follicle. So the LH has an important role in the first meiotic division and the ovulation to occur. And this results in luteinization of the granulosa cells, resulting in the secretion of progesterone, and we all know how important the progesterone hormone is to maintain the early pregnancy. So, what is the pre-treatment consideration? Now, before we take the patient for ovulation induction, we should know the day 2, day 3 FSH, LH, E2, and AMH. Now, these hormones, they have their significance in their own way. Like we all know that in polycystic ovaries, the LH should not be high. The LH FSH ratio is important, the estradiol and the AMH. So AMH value tells us how moderate or severe the polycystic ovaries may be and how the patient is going to respond to our stimulation. Then the thyroid profile and serum prolactin is important, because if there is a prolactinemia, we have to put the patient on the drugs. The DHEA and pre-testosterone indicates the androgenic state. As we know that these patients, they are more prone for diabetes and all the metabolic syndrome. So it is important to check for GTT and lipid profile. Then before stimulation, day 2, day 3 scan is important, and it has to be transvaginally to check for the ovarian cyst, number of the antral follicle, and to check for the endometrial thickness. It should be less, and then only start the stimulation. Before stimulating a patient, the tubal patency has to be ruled out. The tube should be patent. So this can be tested either with sonosalpingography, hysterosalpingography, or by laparoscopically. Laparoscopically is advisable when we are predicting any other pelvic pathology as well. Then the husband semen parameters need to be ruled out before starting the stimulation for the patient. The preconception counseling again is very important, especially in these PCO patients. So one need to identify the risk factors for the reproductive failure, and their correction is important before initiating the treatment. The importance of lifestyle modification, especially the weight reduction, exercise, healthy diet in overweight women, to avoid smoking and alcohol consumption. Then how the treatment is going to be advanced, what will be the duration of treatment, which drugs we are going to use, what will be the protocol which will be followed, what the cost of the treatment which will be involved, and what are the risks associated with polycystic ovarian syndrome patients. So during the stimulation, in the early pregnancy, during the pregnancy, they should be aware of all the risks which are associated with PCOS. And the aim of management should be the unifollicular ovulation in these patients, and to minimize the risk of ovarian hyperstimulation syndrome, and the multiple pregnancy needs to be avoided. So we come on to the lifestyle modification, and this is the first line treatment for these patients. And this include the calorie restriction with any hypocaloric diet, which is reduced by 500 kilocalories per day, and the physical activity of 60 minutes per day up to 3 months, along with the restriction of other risk factors like intake of caffeine, alcohol consumption, and smoking. So they should be made aware of how important the lifestyle modification is to initiate the treatment. Should there be a cutoff weight or the BMI? Now, we all know that obesity reduces the chances of conception. It increases the risk of miscarriage, increased rate of congenital anomalies, and when the patient gets pregnant, there are higher incidences of miscarriages, gestational diabetes mellitus, then hypertension during pregnancy, increased risk of intrauterine growth retardation, and the preterm delivery. So weight loss, how much should be the weight loss? At least 5% to 10% reduction in weight will achieve 30% reduction in visceral fat. So this will improve the metabolic and the endocrine profile, and there will be significant improvement in the reproductive function and the outcome of the patient. Now, how does the elevated LH play an important role in PCOS? So this is observed in approximately 40 to 60% of the PCOS patient. And if there's a tonic LH secretion, this may result in an ovulatory cycles, premature luteinization, failure of fertilization, and there may be higher incidence of miscarriage. So what should be done for this elevated LH hormone? And how does the pre-treatment with OCP pills helps in polycystic ovarian syndrome? So we all know that hypothalamo-pituitary ovarian axis, when we give them contraceptive pills, so we can make use of this negative feedback loop to suppress the LH level. So estrogen forms a negative feedback loop by inhibiting the production of gonadotropin-releasing hormone in the hypothalamus, and they will be thereby reducing the LH hormone. So ovarian production of androgens are reduced and normalization of the LH and the FSH ratio. The suppression of HPO excess for 2 months with COCs followed by clomiphene citrate or any other stimulation method of ovulation induction results in good rates of folliculogenesis in women who were resistant with clomiphene citrate cycles. So it has been observed that 16.13% conceive with IUI in the first CC cycle following OCP pre-treatment, and remaining 26 patients showed good folliculogenesis in the second cycle too, but did not conceive. So pre-treatment with these pills reduces hyperandrogenism by reducing the LH and is recommended for at least 2 to 3 months to reduce the LH hormone 3 times the basal level. So before moving on to the actual ovulation induction, the pre-treatment consideration is important. If there is any symptoms or the risk associated, then that needs to be corrected before actually starting on to the ovulation induction. Now, how does the metformin play an important role in PCOS patients? Well, it improves the reproductive function. It also improves the response to both the clomiphene citrate and the gonadotropin-induced ovulation. This has been reported by the studies in 2003 and by the Cochrane review. So it is recommended in PCOS patient with impaired glucose intolerance, in obese patient, and it is who administered with clomiphene citrate, or in patients who reported the clomiphene citrate resistant, or in cases where we expect the high risk of hyperstimulation or patient going into the hyperstimulation syndrome. So initially the starting dose is with 500 milligram daily during the main meal of the day for 1 to 2 weeks, which is followed by 500 milligram per day weekly or bi-weekly if required until a maximum dose of 1500 milligram to 25 milligram per day. So we start with 500 milligram for 1 week, and then it is increased so that by the time the patient also body get just used to the metformin. And if there is any side effect worsened with increased dose, then maintain the correct dose for 2 to 4 weeks until the tolerance is developed, and then later increase the dose. So this is a study which shows the ovulation and pregnancy rate with metformin in PCOS patient, and if you see these charts, definitely the metformin is combined with clomiphene citrate, the pregnancy rate and is better, and the responders, if you see the 6 months of metformin improve the menstrual cyclicity and the fertility in women with PCOS. So the response becomes better and the increased chances of pregnancy. So before starting the stimulation or deciding for the ovulation induction, these are the certain parameters. Accordingly, we take a call which drug to give to the patient for ovulation induction and what should be the starting dose of stimulation. So the age, we all know, is a very important parameter. Then the BMI of the patient, antral follicle count, the AMH, number of years of infertility, infertility factor, what are the other related factors which is resulting into the fertility problem, and the previous response to the ovulation induction. So these are the basic parameters which help us to decide what should be our protocol, what drug we need to use, and what should be the starting dose and how we have to move ahead. So if we look at the correlation of AMH with fertility and treatment protocol, so where both the AMH and the AFC is there, and as the AMH increases, the antral follicle count increases, and this tells us how the patient is going to respond with a stimulation. So if the patient, the AMH is in between 2 to 4 and the antral follicle count is 10 to 15, there we expect uh, the good success rate and the optimum response. And where both the AMH and the AFC count goes high, there we have to be very careful in our stimulation, need more intense monitoring, and we have to be careful about the ovarian hyperstimulation syndrome. Now, one has to provide a regime which is most appropriate in terms of age and duration of fertility, cause, the pregnancy outcome. Then we'll have to look for the value for money. The patient, the affordability should be there, and which also minimize the emotional distress to the patient. So these are the drugs which are used in ovulation induction. Anti-estrogen, we know clomiphene citrate and the tamoxifen. Then the aromatase inhibitors like the letrozole, gonadotropins, and HMG or FSH. You all know they are available in the urinary form, highly purified form, or the recombinant preparations. Then the drugs which are used to prevent LS surge, they can be analogs like agonist and the antagonist. Then we use certain adjuvants to improve the response to these ovulation induction drugs. And these are metformin, inositol, basically the metformin is more commonly used. Then the bromocriptine, if patient has hyperprolactinemia, dexamethasone, if patient has hyperandrogenic state, and ovarian drilling, if patient is not responding to the clomiphene citrate, if medical induction fails, and there are other indicators when we look for the ovarian drilling, which we'll see later. So for the PCOS patient, we know the first line of management is exercise, weight loss, and lifestyle modification. This is the most important thing. Then we look at the insulin sensitizers, which patient we need to put on metformin, clomiphene citrate, or the aromatase inhibitor. This is the fourth line of the ovulation induction drug. And if it fails or the patient is not responding to these drugs, then is the gonadotropin. And in gonadotropin is a chronic step-up protocol. So clomiphene citrate, we all know, is a competitive inhibitor of the estrogen, and depending upon the BMI of the patient, the starting dose may be 50 milligram or 100 milligram from day 2 for 5 days of the cycle, and this can be increased up to 150 milligram depending upon the patient responding to the drug. It has been reported 70% is the ovulation rate, and the pregnancy rate is 40% with clomiphene citrate. Then, as we are aware, there are certain drawbacks also, like the obese women, they require higher dose of clomiphene citrate, and it has anti-estrogenic effect, as is the competitive inhibitor of the estrogen, and the half-life is 30 to 60 days. Now, the follicular monitoring is important with these patients, and it need to be started from day 9 or day 10 of the cycle. And once the follicle reaches the dominant stage of 18 to 20 millimeter, we check the estradiol level. And as we all know that per follicle, the estradiol level should be 150 to 200 picogram per ml. And when the level is reached to this extent and the follicular size is good enough, 18 to 20, we need to check the endometrium also along with the follicle. We should also be trilaminar. And when we see the cervical canal, check for the cervical mucus. Then the ovulation is induced either with 5,000 or 10,000 units of SCG, and accordingly, if the patient is advised to try naturally, or if the patient has been planned for IUI cycles, and the IUI is timed. So the patient is ovulated, and you see the nice mucus in the cervical canal with the good trilaminar endometrium. So this indicates that The two things, the follicular genesis and the endometrial pattern with the thickness, they both are corresponding to each other. So this is a good time to give the trigger to the patient and time the cycle. Now, sometimes because of the anti-estrogenic effect, you can see this kind of the picture also, where you see the follicular monitoring, the follicles are there, but the endometrium is too thin. So such patients should not be taken for clomiphene citrate in the next cycle if nothing happens this cycle. Now, whether to give SCG in CC cycles or not, it has been studied that routine addition of SCG at mid-cycle does not improve the conception rate, but definitely as it helps us in timing of the intercourse or IUI. So 75% of the conception occurs during the first 3 CC cycles, and if no pregnancy is achieved within 5 to 6 cycles, then alternative therapy should be chosen. Now, when the patient fails to ovulate, that is, not responding to clomiphene citrate, we should look for the conditions like hyperandrogenic state or the BMI or the high LH or the high insulin resistance. So these are the conditions when sometimes the patient fails to respond to the clomiphene citrate. So reasons for the clomiphene failure would be because of the anti-estrogenic effect, which may have effect on the cervical mucus and the endometrium, or there could be high LH. So because of this also, patient may not be responding to the clomiphene. This is another drug, tamoxifen. The dose is 20 to 40 milligram per day from day 245 till day 5, but it has less anti-estrogenic effect if we compare it with the clomiphene citrate. Ovulation rate is 56%, but it is very less often used as compared to clomiphene, as the abortion rate has been reported to be higher than the clomiphene citrate cycles. Another most important drug is the aromatase inhibitor. Now, we are very commonly using the aromatase inhibitors now into a practice, and the dose is 2.5 to 5 milligram from day 2 of the cycle for 5 days, or another protocol is to give 20 milligram as a single dose on day 3. Now, the advantage is it has the short half-life of 45 hours as compared to clomiphene, so there's a rapid clearance and no accumulation of the metabolites. It has no anti-estrogenic effect, so no detrimental effect on the endometrium or the cervical mucus. Then, because the negative feedback mechanism is not turned off, so less chances of developing multiple follicles. It improves the treatment outcome by reducing the supraphysiological estrogen level when multiple follicles are formed. This is an added advantage because it keeps the E2 levels low, so there is a reduced risk of ovarian hyperstimulation syndrome as well. There are studies which say that letrozole has shown to be effective in inducing ovulation and pregnancies in women with anovulatory PCOS cycles and in patients with CC resistance or failure. So if you compare both of them, aromatase inhibitors versus clomiphene citrate, the meta-analysis and 4 RCTs, which says the aromatase inhibitor is superior in terms of pregnancy rate and deliveries. Again, there's a study which says that in CC-resistant PCOS, it improves the chances of ovulation and the pregnancy rate as well. So this is a study which is done by Tulindi in 2006. When the pregnancy is compared, we can see the number of cases of pregnancy in the letrozole cycle. The major malformations were observed more in clomiphene citrate cycle. VSD, again, the risk is high. The total cardiac anomalies risk is high in clomiphene citrate cycle as compared to the letrozole cycle. So if both the clomiphene and letrozole fails or the patient is not responding to these drugs, then another protocol is to combine gonadotropins with either clomiphene citrate or aromatase inhibitor. So the protocol which is used is we can start this clomiphene citrate or aromatase inhibitor from day 2 or day 3 of the cycle for 5 days and add on HMG or FSH, either 75 units, 150 units depending upon the patient response and the patient other history on day 5, day 6 or day 7, and then call the patient for follicular monitoring and then decide accordingly for the further dose of the gonadotropin. So gonadotropin now is a second line treatment, and it's usually recommended when for not exceeding 3 ovulatory cycles with clomiphene citrate resistance or failures to conceive who are anovulatory, or when there is no other subfertility factors. So when we are taking the patient with the gonadotropin cycle, the counseling is very, very important on the need for strict monitoring of the cycle, the risk of ovarian hyperstimulation syndrome, and the risk of multiple pregnancy, the cost of the treatment, because these gonadotropins are costly, the risk of the chances of cycle cancellation criteria if the patient does not respond to gonadotropin as well before starting the treatment. The recommended starting dose of gonadotropin, again, it varies from individual to individual, and depending upon, as I told you, there are so many factors on which the dose depends. So the starting dose can be from 37.5 units to 50 units per day for 7 to 10 days, with small increment of 50% of the initial or previous dose. And if the follicle is more than millimeter, is not developed, then you can keep on increasing the dose. And if the follicle size reaches to 14 millimeter, then maintain the same dose till the follicle reaches 17-18 millimeter in size, and then the trigger is decided. So there are various regimes of the gonadotropin. They can be chronic step-up protocol, or the step-up protocol and the step-down protocol. Now, if you look at what should be the starting dose or the daily dose of recombinant FSH, there's Besoni criteria. Now, depending upon the age, upon the BMI, and upon the basal FSH and the AFC count, is recommended the dose of the recombinant FSH. So, if the AH is less than 35 with patient of normal BMI, and the basal FSH is less than 8, AFC is more than 14, then start with 100 units of FSH. I think this is for the basically for the IVF cycles. Then age, when it is less than 35, BMI is 25 to 30, and basal FSH is less than 8, but AFC is more than 14. Because the age BMI is high, then accordingly we can start with 150 to 200 units of the dose of FSH. If the age is 35 to 40 and the basal FSH is on the higher side, where AFC is less than 14, then it can be from 200 to 250 units of recombinant FSH. So what is the preferred gonadotropin? Whether it has to be the recombinant preparation or the highly purified preparations of FSH, HMG, or urinary preparation, whether we should give only the recombinant preparation or the HMG preparation. Now, there have been the meta-analysis and RCT which shows that all commercially available gonadotropins, they have similar efficacy and the safety profiles. It's a very little difference between the recombinant FSH and the HMG in the outcome. It can be in terms of the dose requirement, in terms of days of stimulation, and the number of the oocytes retrieved, estradiol and the progesterone level, and the clinical pregnancy and the live birth rate. The one advantage of recombinant preparation over the HMG preparation is you can adjust the dose of recombinant FSH. You can start with 37.5 units or 50 units. While if we are using HMG, then because are not available in 37.5 or 50 units of dose, so it has to be from the starting dose has to be from 75 units. So this is a study which used the recombinant preparation in PCOS patient versus HMG, and they've demonstrated HMG to be superior to recombinant with regard to the clinical outcome without increasing the chances of ovarian hyperstimulation syndrome. Now, if we look at this low dose recombinant FSH protocol, this is a recommended starting dose of gonadotropin from 37.5 to 50 to 75 units given for 10 to 14 days. A small dose increment of 50% of the initial or previous dose if the follicle is more than 12 millimeter is not developed. If the follicle has already reached to 12-14 millimeter, then you can continue with the same dose. And the ovulation is triggered when there's a development of the leading follicle of more than 18 millimeter in size. So the advantages of this low dose regime is a careful whenever we are using gonadotropin, we have to be careful for monitoring and the strict criteria for SCG to be there depending upon the number of the follicles, number of follicles less than 14 millimeter in size, number of follicles more than 14 millimeter in size, and if single follicle more than 17 millimeter or less than two follicles in, or how many number of the follicles less than 14 millimeter, because we know if the number of follicles more than 14 millimeter are more in number, then more risk of going into hyperstimulation syndrome. So the low dose gonadotropin, if you look at the summary, this study was conducted, and there the pregnancy rate was 40%, the ovulation cycle 23%, ovulation single monofollicular development in 71%, OHSS risk is very low, and the multiple pregnancy risk is also low when we're using the low dose gonadotropin regime. So the step-up protocol, the starting dose is 75 units from day 2 to day 3 of the cycle, and then it is increased by half of the ampule every 3 to 5 days depending upon the follicular growth, and then the dose is maintained or reduced once the follicle reaches to more than 14 millimeter in size. So this is the step down protocol. Now step down protocol means when we are starting with little higher dose of gonadotropins, and once the follicle size reaches more than 10 millimeter, then we are reducing the dose of the gonadotropin. So this protocol is usually followed in IVF cycles. So here the starting dose is usually from 100 to 150 units for 3 to 5 days, and once it reaches to 10 12 millimeter, then the dose is reduced to maintain the growth. So if you look at the advantage of this regime, it looks more physiological, and the patient gets stimulated within 9 to 10 days of the cycle, while the disadvantages, there is increased risk of multiple pregnancy and the hyperstimulation, and the intense monitoring is required if you are using step down protocol. So the step up protocol is safer and is more efficient than the step down because the lower rate of overstimulation and the higher rate of monofollicular cycles. So what to do if we have more than 4 follicles of 16 millimeter in size and more than 8 follicles of 12 millimeter in size, and if the E2 level is more than 1500 picogram per ml? Should we go ahead in that particular cycle, or what options we have, or how we are going to counsel at this stage? Because at this stage, if we look at the number of the follicles growing, they are much more, so the risk of hyperstimulation and the risk of multiple pregnancy is going to be high with this patient in this particular cycle. So withhold the SCG and wait for the spontaneous rupture. Use gonadotropin releasing hormone analog as a trigger to prevent the hyperstimulation, or to convert the cycle into an IVF cycle with the help of gonadotropin releasing hormone antagonist. Either you can refer the patient for IVF, or if you have the IVF facility in your setup, then convert the IUI cycle to the IVF cycle. Now this is a study which compares the clomiphene citrate with the FSH or the gonadotropin stimulation. So here the patients per protocol cycles, the numbers, the pregnancy if you see is much higher in the gonadotropin cycles. The miscarriage rate is small as compared to clomiphene citrate. The multiple pregnancy risk becomes higher if you are using gonadotropin. The risk of the pregnancies per cycle is also going high in FSH stimulation cycles, and the live birth rate is also higher in gonadotropin cycles. Similarly, we see the cumulative live birth rate is higher in FSH cycles as compared to clomiphene cycles after the 3 consecutive cycles. Now, should we use gonadotropin analogs in our IUI cycles, or if we are using analogs, then when to use them? This is used only in suppression of excessive LH during the follicular phase, or suppression of the premature LH surge or to induce the endogenous LH surge. So, if the patient has the history of premature LH surge, or if there's excessive LH during the follicular phase, then only it's wise using the analogs in the IUI cycles. And the disadvantages of analogs when used in IUI cycles are the increased duration of the therapy, and the cycle become costlier because then you have to use the gonadotropins, higher chances of ovarian hyperstimulation syndrome, and the risk of multiple pregnancy. And if you see it statistically, there's a significant, not much significant increase in the pregnancy rate. So there is no advantage in routinely using the gonadotropin releasing hormone analogs in conjunction with gonadotropins for ovulation induction in women with clomiphene resistant PCOS. What are the advantage of gonadotropin antagonist protocol over the agonist protocol usually in the IVF cycles now? These days, I don't think so anyone is following the agonist protocol, especially in PCOS patient. Now we have already switched over from the agonist cycles to antagonist cycles because it improves the patient compliance. There is fewer number of stimulation days, the lower dose of gonadotropin administered, and significantly low incidence of hyperstimulation syndrome. Versus, and before starting taking these patients for ovulation induction, is as I told you earlier, assess the ovarian reserve and check the AMH, the enteral follicle count, and then decide the dose of the gonadotropin. So, what strategies can be used to optimize the COH in hyperresponders to keep the dose of the gonadotropin low? This is basically the IVF cycles. In IUI cycles, keep the start from 37.5 units to 50 units should be the starting dose, the minimum stimulation protocol to be followed. Monitor the patient at regular frequent intervals. Resist the tendency to increase the dose unless there is a total lack of the response. Then posting is another protocol which we can follow, that is the withhold of gonadotropins for 1 to 3 days before giving the SCG trigger if you have taken for agonist protocol. Avoid agonist protocol and use the antagonist protocol, which is much safer compared to agonist protocol, because if we are taking the patient for agonist protocol, then there we have to give SCG as a trigger. If we are using antagonist protocol, then the agonist can be used as a trigger, so we are on the safer side as preventing the OHSs. And then freeze the embryos, counsel the patient to go for cryofreezing of all the embryos, cancel the fresh embryo transfer in that particular cycles, and once the ovaries they come back to the normal, the hormones come back to their normal, then plan for the frozen embryo transfer cycles. So then we come to laparoscopic ovarian drilling. Now, when laparoscopic, is it mandatory for all the patients to go for laparoscopic ovarian drilling, or there are certain indications only when we take patients for ovarian drilling? And what is the mechanism? How does it helps in PCOS patient? It reduces the LH secretion. There's a reduction in inhibin, which increases the FSH, release of growth factors in response to injury, and it augments the effect of FSH on the folliculogenesis. So, it is advisable only in patients who fail to ovulate with the medical therapy. So the advantage of this drilling is it does not require intense monitoring, reduces OHSs, reduces the dose of gonadotropin required, and patient starts ovulating within 6 to 12 weeks. The complications are pelvic adhesions and the risk of premature ovarian failure. So if you're advising for laparoscopic ovarian drilling, you have to be very judiciously advised to the patient for this procedure only when the patient is not responding to the stimulation, or if patient lives in the remote area and cannot come again and again for the follicular monitoring. So if we look at the indications as per the RCOG, ACOG and these society guidelines, when there is a resistance to the first line treatment with clomiphene, persistently hypersecretion of LH hormone, or subject requiring laparoscopic assessment of their pelvis for any other pelvic pathology, or if there is lower access to the healthcare facility. So use either cautery or laser to create up to 4 to 5 superficial perforations per ovary, and the unilateral, you can go for unilateral ovarian drilling, is as efficacious as the bilateral ovarian drilling in terms of ovulation and the pregnancy rates. Premature luteinization is more commonly seen in these PCOS patients, and we know that in these PCOS patients, sometimes the serum progesterone level hormones, serum progesterone level goes up on the day of the trigger, especially when the patient is stimulated with the gonadotropin. So usually the same progesterone hormone should be less than 1 on the day of the trigger, because if it goes above, then it may be affecting the endometrial receptivity and may be compromising on the implantation of the embryo. So earlier it was thought that it is because of the HMG which results in premature luteinization. But once the studies were done by Marco Filigori, it has been reported that this secretory endometrial transformation or premature luteinization was because of the FSH stimulation, FSH gonadotropin used as compared to the HMG cycle. So HMG administration or FSH supplementation with 50 units of LH did not significantly affect the serum progesterone level. So HMG administration in a way is more safer as compared to FSH throughout the cycle to prevent this premature luteinization. So this is a study which says that yes, HMG lead to lower P4 level on the day of SCG as compared to recombinant FSH and recombinant LH. So, what are the effects of ovarian stimulation on the luteal phase? So, when we are stimulating a patient, there can be a supraphysiological level of E2 and progesterone. And this supraphysiological level of E2 and progesterone may have a negative feedback and resulting into the suppression of LH and FSH in the early luteal phase, resulting in regress of corpus luteum and the short luteal phase or the luteal phase defect. There can be asynchrony in between embryo and endometrium. And if you're taking a patient for oocyte retrieval or the ovum pickup, because of the ovarian aspiration, there may be granulosa cell disruption and aberrant steroidogenesis. So, what can be the complications of ovulation induction on these patients? The risk of multiple pregnancy be up to 36%. The risk of hyperstimulation is there. The patient is developing multiple follicles. The risk of ovarian torsion if the ovaries they become bigger in size, and the risk of cancer in these patients. But till date, no causal relationship has been established. So the take-home message for these patients, especially PCOS patients, when we plan for ovulation induction, is the proper patient selection, the necessary investigations to be done before planning for ovulation induction, and the lifestyle modification counseling is very important for these patients. Start with clomiphene or the aromatase inhibitor to begin when we are beginning the first few cycles. Should not exceed more than 6 cycles with the clomiphene or aromatase inhibitor. And if the patient has not responded within these 6 cycles, then move ahead. Follicular monitoring is mandatory, more intense with gonadotropins cycle. E2 level is important when there is a multifollicular response because it will help us to decide for the treatment plan. Proper timing of the SCG trigger or the agonist trigger is important to time our IUIs if we are planning for IUI cycles. Ovulation trigger with agonist when there is a risk of OHS is high. Luteal phase support in these patients is important because it may result in early regress of the corpus luteum or luteal phase defect. Ovarian drilling only if medical induction fails, and take all the necessary measures to prevent ovarian hyperstimulation syndrome. So, with this, I end my talk, and now I would like to have the interactive session with all the participants. Okay, I have received a query how to manage if there is a follicle more than 14 millimeter on day 2 of the cycle and if this cycle is planned for IUI. See, if the patient has already a follicle of more than 14 millimeter, I would not advise to go for stimulation in this cycle because here the baseline E2 levels may be on the higher side. So you can just follow this cycle naturally, or you can give the contraceptive pills to suppress this follicle of 14 millimeter and then plan for the ovulation induction in the next cycle. And another query is which ART protocol would be best suited for a 30-year-old obese PCOS patient. Now, it's not only the age and the BMI, there are many other things. Has she taken any treatment earlier? If she has already taken the clomiphene citrate or aromatase inhibitor, then I'll not start with these. We'll switch on to gonadotropin. But because she's obese, it's important to know how much is the BMI of this patient and to counsel her for lifestyle modification to reduce the weight to at least 5% of the body weight to improve the response for the ovulation induction. So as I have told you in my this thing talk that lifestyle modification is the first line treatment, and then as she is obese, so put her on metformin to improve the response of any kind of the stimulation. There's another query by Dr. Pankaj from Pune. In a case of resistant PCOS who undergo ART or ICSI on role of pre-treatment with gonadotropin releasing hormone analogs or OCP E2 before frozen embryo transfer cycles. If you are very specific about before frozen embryo transfer cycles, then it's better to keep them on OCP to suppress the LH hormone. And if she has a tonically high LH, then you can take this patient with the analog cycle. Also, you can suppress the previous cycle, put her on ACP, and then give her agonist depot preparation. And when she starts bleeding, you can start preparing the endometrium with the estradiol. There's a query from Dr. Mayur from Mumbai. Do you recommend CC or Letrose plus FSH or PCO or normal ovaries? See, especially for PCO patient, if she has not responded to clomiphene or Letrose cycle, you have to counsel the patient that she need to move forward with the gonadotropins. Now, it would be better if we take her for gonadotropins alone, but if the monitoring is the problem or if there's a financial constraint, you can plan for the combination cycle, that is the CC with Letrose and FSH. And if still the patient is not responding, then you have to counsel the patient for the gonadotropin cycles. Patient has already taken CC2 cycles 1 year back, again came after 1 year. How many cycles we can give? Now, here I would like to know what is the age of the patient and what is the duration of infertility and what are the other factors like the AMH and the AFC. If she's already taken 2 cycles and has come 1 year, if all the factors are in her favor, then you can move on to aromatase inhibitor and see how she's responding because she has already taken clomiphene citrate 2 cycles earlier and she did not do well. So, what should we do to reduce the miscarriage rate of pregnancy after laparoscopic ovarian drilling despite use of progesterone suppositories? So, this is by Dr. Lena. Now, here, if she has a history of miscarriage already earlier, then we have to rule out the other causes of miscarriage. We need to check what is her progesterone, whether she has the luteal phase defect or low progesterone level during her early pregnancy. And this patient, if she is on the obese side, then to reduce the risk of miscarriage, the better is to put her on metformin therapy. So, truly speaking, I have not used clomiphene citrate along with letrozole. Either I prefer clomiphene citrate alone or letrozole alone. I have used clomiphene citrate with gonadotropins or letrozole with gonadotropins, but not these two together. So, sorry, I cannot share. I have no experience with these two drugs I use together. So one of the question is what is the ideal dose of SCG for trigger? You can use either 5,000 units or 10,000 units per clomiphene cycle. Is no as such ideal dose, and it depends upon the E2 level also. If the E2 level is high, then better not to give the SCG than use the agonist or give only 5,000 unit of SCG trigger. Management for repeated unruptured follicles. You need to see what is your protocol for ovulation induction. If with a particular ovulation induction drug there is a history of unruptured follicle, then you can change your mode of ovulation induction. You can maybe the timing of the trigger is not right. Check for the E2 level and the LH level when the follicle reach the stage of maturity, and then decide for your trigger time. Or you check your trigger. You can give the combined trigger SCG and the agonist, or you can only give the agonist if you have already tried with the SCG earlier. In a PCO patient, the dominant follicle size is 19, 18 millimeter. So, what is the right time for SCG trigger? It is a timed cycle. So, if for the timed cycle, and if you're planning to give the trigger, then check for the E2 level, because sometimes if in the stimulated cycle also the E2 level may not be corresponding with the follicle growth. Or I have seen in my experience, if you're stimulating a patient with aromatase inhibitor, if even the follicle size has reached up to 19-18 millimeter, the E2 levels sometimes are very low. So if the E2 levels are low, then you have to wait for 1 or 2 days more for the SCG trigger. And you can simultaneously, during the monitoring, can also see the endometrium. If the endometrium is not corresponding with the follicular growth, and if the cervical mucus is also lacking, that means that also indicates that E2 level may be low in this particular site, in this particular patient. So there you have to wait for the endometrium to grow up, or by checking up with the E2 levels, you can decide your time of SCG as a trigger. In LUF, I have already told you earlier, we have discussed one question earlier also. If the patient has repeated history of unruptured follicle, then you have to change your protocol for ovulation induction, change your protocol for the trigger. If you are using SCG, use agonist. If you are using the 5,000 units only, give 10,000 units. Maybe your timing of trigger is not right, so patient is going into LUF. In spite of taking all these in precautions, patient is having LUF, then advise them to go for IVF. Sorry. Now, there is a question by Dr. Shobha, how to manage fluid in endometrial cavity with good follicle and without evidence of infection. See, sometimes this fluid in the endometrial cavity may be because of the backflow of the mucus also. And if you monitor such patient 1 or 2 days later, you will see the fluid if it is a non-infective fluid and if it is because of the mucus in the canal or the secretory fluid in the cavity around the time of ovulation. This will not be seen 1 or 2 days later when you do the monitoring. It will disappear on its own. Another query is, can we give the antagonist if the follicle ruptures spontaneously at 12 to 14 millimeter? So this indicates the patient has the tendency for premature luteinization or premature rupture of the follicle. So here you can take the patient for antagonist cycle and then add gonadotropins 37.5 or 75 units, and then you can time your SC trigger and take the patient for IUI cycles. There's a query by Dr. Mansa. Patient with ovarian cyst of 3 centimeter with history of PCOS and anxious to conceive, can we give ovulation induction drugs? To this patient, at present, I would advise no, because she has ovarian cyst of 3 centimeter. Now, no, you have not mentioned whether it's a clear cyst or it's a physiological cyst, it's an endometriotic cyst. You have to find out what kind of cyst it is, and so it's not advisable if it's a simple follicular cyst to induce this cycle. Either give her contraceptive pill to suppress the cyst, wait for the next cycle. Again, in the next cycle on day 2, check for the ovaries to rule out this cyst, and if the cyst is not there, then only progress further for the ovulation induction. So I think with this, there are no more questions now. I think I've already shared in my last slide the take home message. Again, I'll share it. So, especially in PCOS patient, the proper patient selection is very important. Counsel them how the treatment is going to go ahead and all the associated risk factors, the plan of treatment, the cost involved, the duration of therapy, lifestyle modification, the necessary investigations and workup before starting the stimulation. Then, if the patient has not taken any of the stimulation drugs earlier, then start with clomiphene citrate or aromatase inhibitor, which should not be for more than 6 cycles. If the patient respond with these stimulation, good. Otherwise, move on for gonadotropin stimulation. The proper timing of the for the trigger is important, whether you're planning for SCG trigger or agonist trigger. Then, because these patients they have a luteal phase defect invariably, so the luteal phase support is very important. All the precautions to be taken to prevent ovarian hyperstimulation syndrome. Patient should not go into this condition, should not reach to this condition, and aim for monofollicular response. Ovarian drilling is only advisable if the medical induction fails. So, with this, I end my talk, and I hope the participants or the viewers have benefited with this talk. So, thank you so much to be here with me today with this session and making the putting up the questions, and I hope I have solved all the queries of yours. And with this, I thank to IFS for giving me this opportunity to guide us, and to the Doc Mode for this educational platform. Thank you so much. Thank you.